Hello everyone. Hello. Welcome to this talk update. A very important topic for part 1, 2, and 3 candidates. Vaginal pessaries for pelvic organ prolapse. So we are going to talk about this talk today and simultaneously we'll be solving some questions as well to get grasp of concepts very clearly. So, first of all, welcome you all at this time for this talk article. And I know many of you are waiting for it actually, particularly the part 3 students, because it's a recent talk article and very important for your exams as well. But it is also important for part 1 and part 2 students also. So, the questions I'll be taking at the end, and that is questions not related to what you want to ask. It is about some single best answers and some pointers to discuss if it's a structured discussion task. So let's stay till the end to go through those questions as well. And secondly, your questions are welcome at any time during the presentation because as you all know, I love interactive sessions. So if you have any questions in between, you are welcome to or ask in between as well. But just raise, you can put your questions in the live chat and I will be answering those in between as well. So here we go. So once again, my lovely students, welcome you all. I can see many of the students have really joined. So as I can see, let me take few of the names. So here it is Dr. Swati. And yes, Dr. Salma Parveen. Yes, great. So I can see many of those um, students here, and I welcome you all. And let's start with this topic today. And do keep writing in the live chat. I will be happy to see you all, hear from you all. So, yes, Dr. Lubna, Dr. Birza, Dr. Sushmita, Dr. Nupur, Dr. Anjali, Dr. Shiva. So, yes, thank you. Thank you so much for joining in today. So, here we go with this topic. It's going to be a short session, 15-20 minutes. What we will cover in the next 25 minutes is the evidence. Does the Pessary actually work in this scenario? Should we actually use it? PopQ, describing prolapse objectively. 6 pessaries, what each one is for. Selection and fitting, the practical craft, which is very important for the part 3 students. Follow-up intervals and the self-management, very important for both part 1, part 2 and part 3. Complications, recognize them and treat. And then in the end, we are going to take up single best answers and we are going to do that now. Does it actually work? What is the evidence base for pessaries in pelvic organ prolapse? So if I talk about the numbers, we all love numbers, right? We love the evidence-based practice and that depends on the number itself. So that is why this first slide is for the numbers. Numbers are very important for the part 2 exam as well. So 50% of the Paris women develop prolapse in their lifetime. 90% plus relief of bulge and pressure if you have successfully fitted the right size. So 90% plus patients get benefit. 60% of women fitted choose to continue long term and 4 RCTs in the latest Cochrane review which has proven all this. Pessaries also improve the urinary voiding, urgency, urge incontinence, bowel evacuation and the sexual satisfaction and they are recommended by the NICE as the conservative option. What the Cochrane review actually says. If I talk about these studies, you don't need to remember those studies. This is just for your reference. But final verdict you have to remember. That is Pessary plus PFMT. Pessary plus pelvic floor muscle training. This is the one highlight. So it is the combination that carries the evidence. This is the most important point here from this particular slide. So combination of pessary plus pelvic floor muscle training. Now how this is going to show up in your part 2 exam. In EMQs you will have one option of only the pessary and the other one is the PFMT plus pessary. Obviously PFMT plus pessary is the better option for you all. Now, describing the prolapse. This is always, I think, POPQ is a pain point for many students, although we have done many times we keep on doing with the sessions and all, but still I think this is something. But let's simplify it for today let's make it so simple that you don't have to bother for it again. So just remember, there are 2 pointers here. Just let me take my pen here. Just a moment. And yes, so you see that this is the anterior vaginal wall and this is the posterior vaginal wall, and then this is the the vaginal canal. Now if you look at this, there are 2 points, AA and BA. So this whole thing is like 3 centimeters, 3 centimeters from the hymen. And on the posterior wall also we have got 2 points, AP and BP, and this is also 3 centimeter from the hymen is the total thing which we are going to take. Although BA and the BP, they are the most distant points, right? They are not 3 centimeter, but they are most distant points. But we are going to take for almost like 3 centimeter above the hymen is the AA and the AP. So this point is basically 3 centimeter and this is the most distant one. Now, whenever the anterior wall that bulges down beyond 3 centimeter, but 1 centimeter. So between 1 and 3. Between 1 and 3, this is going to be this is basically going to be the first stage 1. When we take between +1 and -1 and +1. So anything outside the hymen is plus, inside the hymen is minus, okay? So anything from this is -3. So -3 and -1. This is going to be your stage 1. This -1 and 1 outside. This -1 and -2, anything between this is going to be stage 2. Yes, hymen is the 0 point here. Okay. I think there was a bit of confusion. So let's do it again. So basically the AA is basically your point which is at -3, right? So this is at -3. This is at -3. Now when this wall bulges beyond this, we have to look at what point it is. So hymen is the 0. This is -1 and this is +1. So anything up between -3 and -1 is going to be stage 1. -1, 2 plus 1 is going to be stage 2. And beyond 3, that is stage 3. And then when it's complete eversion, it's going to be stage 4. If you remember this much, you will be able to classify all the POPQ points here. So more than 1 centimeter above the hymenal ring is stage 1. Then more than 1 centimeter of the hymen above or below is stage 2. Stage 3 is more than 1 centimeter beyond the hymen, that is up to TVL minus 2 centimeter, that is stage 3, and beyond TVL minus 2, that is complete eversion, is procedential. The commelin slip is stage 2 straddles the hymen. You see that the hymen comes in the stage 2 because 1 minus above and 1 plus below. So hymen is in the center, -1 +1. So hymen is in the center. Anything within 1 centimeter either side is stage 2. That's what you need to remember. Any questions till now? All good? All good? Okay. So we talk about now let's answer this question. So if I talk about this question, if I talk about this question, who is going to answer this? I'm waiting for the answers in the chat box. So anybody who is ready to answer this question? So if I look at this anterior wall, AA -3, BA -3, no descent. C is 6, well supported. AP is +2, BP is +5. And the measurements of the GH 4.5, perineal body is 1 and the TVL is 8. So let's look at who is going to answer this. Yes. Who is going to answer this? Yes, I can see answers in the live chat. And it is interesting to see. Yes, 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 yes. Yes, very good. So Dr. Nupur Jaiswal is the first one to answer. and followed by Dr. Swati Jain, Dr. Birza, and Dr. Sushmita. So the answer is stage 3 because you see that the BP comes down to +5. So it is much beyond +1. So that is why, and TVL -2 is 6. So it is inside the 6. So this is stage 3 posterior wall prolapse. So this is yes, correct. So many of you have answered it correct. Nice, nice, nice. Okay, so now you have a good idea about the POPQ. Now what to do when you have decided to insert the pessary. Before you reach for a pessary, the examination is offer a chaperone. Very, very, very important. GMC guidance on intimate examinations. Inspect. First inspect the skin changes, atrophy, pelvic organ prolapse at the introitus. Then maximal valsalva, bear down or cuff to assess the descent. This is very important. This is the last time when you are going to assess the descent. Now, isolate each wall and try to look at each wall separately. So either you can use the sim speculum and use it on the posterior wall to see the anterior, or use on the anterior wall to see the posterior, or you can use your fingers. Reposition, frog leg supine, repeat standing if needed. Bimanual examination exclude any pelvic mass as the cause. So remember the 6 steps of examination, particularly important for the part 3 students if you talk about the teaching session of the pessary. The history must cover the prolapse symptoms plus urinary, bowel and sexual function, and whether she can attend for follow-up. And important history points will be urinary symptoms, bowel symptoms and the sexual function, and you have to check whether the follow-up is possible or not. Now, the pessaries themselves. Finally, we come on to the pessaries. Multiple types exist, but we will take you through the 6 main types. So, now what is in the drawer? These are the various things which are available. So, top cube pessary, ring with the knob, right? Ring with the knob is there, cube and the ring with the knob. Then there is a silicon shelf, solid shelf, ring with support. So this is ring with support, and then bottom is the PVC ring, the donut pessary and the gel horn pessary. So basically they are made up of silicone or the PVC, flexible or rigid, and depending on what is the situation of the patient, accordingly we use. Now what are the indications for the various pessaries? That is what we are going to talk today. So if you divide all of these pessaries by mechanisms, then there are 2 types. One is support and one is space occupying. So support is which is just ring with the support, dish or the Schatz pessary. So what does this do? As the name indicates, this provides the support. So you will fit it. It just sits behind the pubic arch on the levator plate, easier to insert and remove and self-manage. And because they occupy less space in the vagina, so penetrative intercourse stays possible. Struggle with stage 3 and 4 or a wide hiatus. So problem is when it is not suitable for the bigger prolapse, massive prolapse like stage 3 and stage 4 or the wide hiatus. Space occupying is like gel horn, shelf, donut, cube that fill the space or create the suction to stay in. They are better retained. So they are good for the advanced prolapse because they will stay in there. Penetrative intercourse is not possible because they occupy the space and they are harder to remove and more complications are there. So support and space occupying, these are the 2 basic mechanisms by which they work. So now from this slide only you know that if a patient is sexually active, space occupying is going to be a problem, or either she has to remove everything. So if possible, you will go by the support. So if you understand these mechanisms, many of your questions will actually get solved. The support pessaries. Now look at this ring plus minus support. It's only the ring. So first line for any stage, anterior or small apical prolapse. Sex is possible because it's a simple ring there. Self, you can insert and you can take it out easily. Poorly retained in stage 3 and 4. Difficult to retain in stage 3 and 4. Now ring with the knob. Prolapse plus stress urinary incontinence, because this knob that will be placed in anteriorly, right? So it treats the SUI. So this is basically for the urinary incontinence, and it does not give you extra support to hold the bigger prolapse. So the purpose of knob is to work for the SUI. So this is very, very important to note here. Now, the sex yes is allowed, self allowed. Then comes the shots. Low pubic arch, ring in not retained, wants intercourse. Sex is possible, yes. Self may or may not be possible for the patient. Gel horn without a stem. If you see the gel horn, there is a small base and then there is a stem. So without the stem, the gel horn, you can see it as a shatz. Now, what about the space occupying pessaries? Gel horn, advanced POP, because it definitely has a stem, it can fit in, so it can hold the massive prolapse. A short TVL, short length, narrow apex, this is good, but sex is not possible because they are space occupying, and inserting and taking out is real torture. So it is hard. Hard to remove and most linked to fistula, because if it stays there, it can lead to erosions. Shelf and poppy, as for the gel horn, but a more anatomical space shape. So 6. No, shelf is hard. So removal can be difficult. Donut, posterior or high stage pop, white hiatus. Sex is not possible and self is hard. Best with the uterus in situ. So this is for the posterior prolapse particularly, where it is like bigger ones. Now this is basically, you see, 3 you should recognize on sight. This is a folding ring, this is ring with knob, and this is the shuts. As you can see, it resembles the gel horn, but it is not having that stem. So this is the shuts. Yes, Dr. Yamini, here is the picture of the shuts. You asked for it and it is here. So note the notches, easiest type to self-manage. Ring with the knob. Knob sits under the urethra for SUI and for a low pubic arch when a ring will not stay in. Now cube. When you look at the cube, right? If you remember from the first picture which I showed you, the cube, and there is a small thread like ring there. But remember that cord is not to pull and take it out, okay? If you do that, it's going to stay there. So basically it holds there with the suction. So the 6 concave sides, there is a convexity here. So concavity on the sides, and this concavity actually exerts the suction. That is why if it stays in, it can lead to necrosis and erosion if not removed. So out every single night and before sexual activity. So it's going to be very, very difficult. Self-management only. If she cannot or will not remove it daily, the cube is not an option. So even if it is difficult to take, she has to learn the self-management. Otherwise, she cannot use the cube. The string is not a pull cord. So it identifies the base, break the suction with the sweeping finger. Never pull it. It is not to pull. You have to break the suction by just moving the finger across it. So sweep the finger and never pull it. So this is basically, it is only for the cases of the advanced prolapse where actually everything has been expelled and nothing has been successful. In only those cases, this is good because you see that there are so many things to be managed in these patients. Okay. Now, selection, sizing, and fitting. So here is the main algorithm which we need to take care of. So ask before you start about the penetrative intercourse, self-management. Is that possible for her to manage by self? Start with a ring, support for apical POP, a knob for SUI, expelled, uncomfortable or not enough support. So if it is expelled, check size, treat constipation, would she reinsert? So this is very, very important. Not supporting, then you have to check the sizes. So actually you have to see expelled or it is basically not supporting. So if it is expelled, Then you have to check the size, treat constipation, and whatever precipitating factors can be there. If she is not supporting, then you have to try other rings. Sexually active, you can look for the dish or shots, but not sexually active, you can go for the gel horn, shelf, or the donut. Still failing, self-manage, probe cube. If not, discuss the surgery. Still, if nothing is working, cube is the last option. But if she cannot self-manage, then surgery needs to be done. Always start with the ring pessary and then go on to the alternative types. So this is basically start with the ring and then troubleshoot. So this is what I've just talked about. This is algorithm I have simplified on that slide, and you can see the simple algorithm is explained all everything which is present on these few slides from the TOG article. So pessary choice chart: before commencing a pessary fitting, inquire if the woman wishes to be sexually active and if she can self-manage. Then you can consider the ring pessary, that is the first choice. Now you look at like if she is having a problem, then self-management is still possible, then you can go for the higher options. If expelled or uncomfortable, then you have to look for the other options. So if pessary is expelled, as we have just talked about, you have to look for the size, or you have to look for what is the precipitating cause, like constipation, chronic things which are worsening it, right? And then see whether patient can do or not do. So consider a different type of pessary. If it is a sexually active, you can consider the bigger pessaries. Not sexually active, then you can use the pessaries like gel horn or the silicone shelf. This all summary I have talked about in that one simple chart. Now, so we have to discuss if patient is not able to take out the cube daily, then we have to discuss the alternative to pessary and other supportive options. Now, what are the contraindications and things to fix first? Do not fit. If it does not fit, cannot attend follow-up. Acute pelvic or vaginal infection is there. Unexplained vaginal bleeding, vaginal or cervical cancer, vaginal erosion caused by the mesh. If any of these is there, patient is not fit for the pessary. Then there are certain things in which you cannot immediately do the pessary insertion, but after some management you will be able to do. So for urogenital atrophy, estrogen, refit at 6 to 8 weeks. Decubitus ulceration package plus estrogen. First heal the ulcer and then see. Previous radiotherapy altered tissue quality. So mesh itself is not a contraindication. Correct the atrophy first. 5 things that predict the failed fitting. You see that these are the things so patient may fail. Previous prolapse surgery, already the failed surgery, previous hysterectomy, short total vaginal length, wide genital hiatus, and posterior compartment prolapse. These are the things where you can predict that this can fail. So previous prolapse surgery, previous hysterectomy, short total vaginal length, wide genital hiatus, and posterior compartment POP. Why it matters? A hysterectomy gives a short tibial and a narrow apex, so a ring has nothing to sit on. Reach for the gel horn, the concave dish suctions into the proximal vagina. Now, for how to fit step by step. Position: frog leg, supine or lateral lithotomy is rarely needed. Size it: 2 fingers in each fornix for the width, fornix to symphysis for the length. So look for, like you insert, then you have the fornix and here you have the symphysis pubis. So that will give you the idea of the length. Prepare it. Warm water clears the residue and softens it. Then lubricate with the gel or the estriol cream. Check the peanut allergy. Insert it. Fold or twist support types. Stem types go inside on and then rotate up. I think I have a picture here. Yes. So you can see this picture here. You are actually pressing it. So as you press, this goes in and then you can fit. Fold the ring at the notches, then let it expand inside. Same for the pliable, say, space occupying types, convex side to apex. And to remove, break the suction with the finger, forceps if that fails. So that is what we need to do. Analgesia is not a routine topical gel for difficult fitting or removal. And then you have to do the trial and error. Sometimes you may need multiple appointments as well. Have you got the right fit? If it properly fits behind the pubic arch, a finger passes around it. You pass the finger, but it is not expelled on standing or straining. Back edge lies posterior to the cervix. No stem is visible at the introitus. Before she leaves, she can void. A pessary that is too large compresses the urethra and causes retention. This is a very important test. As you can see, it is in the red. So this is a very, very important test for the patient. This I have already explained to you how to insert. This is gel horn, inserting and removing. So as you can see, this knob, rigid or stem type, go in, slide on, then rotate and push it up. First insert, then fix it up, rotate and push it up. Removal is the hard part. First you have to release the suction. First you release the suction and then you can use the sponge forceps to take it out. The follow-up and the self-management where the pessary care is actually won or lost. The follow-up timeline, fitting, check, she can void first. 4 to 6 weeks, first review may be by phone. Then every 6 months, patient has to come. This is when she is self-managing. So every 6 months in person, pessary out up to 18 months if she is self-managing. So fitting, check, she can void first. 4 to 6 weeks, you call up her, take a review. At 6 months, she can come in person, and up to 18 months if she is self-managing. At every in-person review, ask about the comfort, whether she is comfortable, how is the fit, what is the mobility and the symptom control. Remove it and inspect vulva, vagina and cervix with speculum for erosion, ulceration or suspicious lesions. Reinsert, replace or stop. Self-management, the top C message, that is cost-effective versus clinic-based care. No worse quality of life. Quality of life is not reduced. Patient is managing herself. She is okay. Complication status, lower. Confirmed at 4-year follow-up, offers self-management to every woman who is able to do that. The flip side is pessary neglect. Sometimes women with dementia or poor access to the care present with the incarcerated Pepsi or a fistula, and that is the worst thing to happen with this particular thing. So how it is managed? What is the pathway? So who manages? Rings in the primary care. Other types need specialist input, usually a urogynecology nurse specialist. And regulation, like they are class 2A under 30 days of continuous room, class 2B up to 6 months. So overall, it's a good thing to be used. Silicone may last up to 20 changes, that is up to 10 years, and a new PVC pessary at each review. Replace if cracked or split. Silicone can last for the longer time, but the PVC pessary you need to change at every 6 months and replace if it is cracked or split. Vaginal estrogen recommended, but read the small print, that is prescribe vaginal estrogen to the woman with urogenital atrophy having a pessary fitted. What the trial shows, but it does not have any benefit in preventing the complications beyond possibly less bacterial vaginosis. But it is highly supported in the patients who have the cancer. It can be used because these patients actually have more of dry vagina. Now, what are the complications? Common ones are benign. The rare ones are the ones which hurt. So now if you look at the complications and the numbers, so increased discharge is very common. Erosion, bleeding, discomfort, expulsion, new bladder or bowel symptoms, they are common. Ulceration, difficult removal, infection and incarceration are uncommon. Fistula is rare and cancer is very, very rare. So you can see increased discharge is the most commonest side effect, and this is going to be a part 1, part 2 exam question. Erosion, bleeding, etc. is common. Ulceration, difficult removal, infection, incarceration is uncommon. Fistula is rare and cancer is very rare. Remember 1 1 in each category. One in very common, one in common, one in uncommon. So this is how you can remember for your exam. Managing the commoner ones. Now, what is the management of these common ones? Increase discharge, reassure if mild, ensure adequate vaginal estrogen. Antibiotics are not needed. It is just you need the vaginal estrogen. Erosion or ulceration, remove the pessary for some time and give vaginal estrogen. Occult stress in incontinence, change the type or the size. For some, it is still the reason they stop. Pain, obstructive defecation, expulsion as above, plus physiotherapy, fiber, laxatives to avoid the straining. So depending on what is the cause, you are going to manage. The three that will land in your on-call: infection, antibiotics, they replace the pessary and if it is colonized with the bacteria. Incarceration, if it is that, oh my God, that can actually be a literally emergency. The pessary dislodges and embeds in the vaginal tissue. Removal may need an anesthetic or cutting a ring may also be required. And the most serious is fistula. That is significant morbidity and mortality. You have to refer to urogynecology. And for small defects, sometimes estrogen may suffice, but depends on what type it is. So untreated atrophy or neglected follow-up are the two main reasons for the complications. These are the various trials which are given as the reference in this article, and the various guidelines are there. So 10 lines. This is the summary which you need to carry into your exam. Start with the ring always. Pessary plus PFMT is what concurrence supports. Stage 3 is greater than 1 centimeter beyond the hymen, and stage 4 is eversion. Then a knob on the ring means coexisting SUI. Post-hysterectomy, short TVL, think gel horn. Cube, self-management only and out every night. Always treat atrophy first. So estrogen, then refit at 6 to 8 weeks. Review at 4 to 6 weeks and then every 6 months. Erosion, remove for 4 weeks plus vaginal estrogen. Fistula is rare, but it is the one with mortality. So these are the 10 main pointers which you need to take care. And now it's your turn. So let's answer few questions. Right, so before I go on to this, so that is, we are going to start. So any questions from your side? Yes, let me check the live chat. If there are any questions, I will be happy to answer those. And else I will start my questions for you all. Hope you all enjoyed the session. Just stay for 5-10 minutes more. So basically, they are going to do that. Okay. So basically, there is a question here that why to note the peanut allergy? Because that is there for the peanut allergy, it is present in the lubricants, right? So the content of the lubricant that may have that allergy, that is the peanut oil. So that is what we need to take care of in as a lubricant, or sometimes we use the estriol cream that also has it. So that is why it is important to note that allergy. Infected ring is sent for the culture and sensitivity too, madam. If it is infected, yes, we can send for the culture and sensitivity. Okay, people have started answering. Very nice. 68-year-old woman attends with the symptomatic vaginal bulge. She had a vaginal hysterectomy 12 years ago. Her total vaginal length is 6 centimeter and the vaginal apex is narrow. 2 attempts at fitting a ring with the support have ended in expulsion or stranding. She is not sexually active and does not wish to manage a pessary herself. What is the most appropriate pessary to try next? So, yes, everybody is correct. It is the gel horn pessary. Previous hysterectomy gives both a short total vaginal length and a narrow apex, so ring has nothing to sit behind. Gel horn's concave dish suctions into the proximal vagina and is well retained. So you can use, and she is ready to self-manage. So that is not a problem at all. Okay, so the fastest finger first is Dr. Sushmita. and Dr. Yamini, Dr. Nupur, Dr. Swati, and something like Dr. User, Dr. Bariza Khan, Dr. Viju Lakshmi. Very good. So let's move on to the next question. 58-year-old woman has used a silicone ring pessary for 2 years. At her 6 monthly review, she reports an offensive vaginal discharge. After the pessary is removed, speculum examination shows a 1 centimeter area of erosion on the anterior vaginal wall. There is no bleeding and no mass. What is the most appropriate management? Yes, what is the most appropriate management? Here, the C is, I think, for the previous question, still carrying over. I'm looking for the new answer. So what needs to be done? Or this is a C for this question? Yes. Okay, yes. Now the answer is going to be D. Perfect. Again, Dr. Sushmita, Dr. Yamini, yes, Dr. Balzam. So remove the pessary for 4 weeks and prescribe vaginal estrogen. Erosion and ulceration of the vaginal wall are treated by removing the pessary for 4 weeks and use weaving vaginal estrogen, a strategy based on case series rather than the robust trial data. Leaving the pessary in situ allows the erosion to progress. Antibiotics are seldom necessary and are reserved for established infection. So that is what is required. 72-year-old woman with the stage 3 uterovaginal prolapse attends for pessary fitting. She is keen to avoid surgery. On examination, the vaginal epithelium is thin, dry, and friable with marked urogenital atrophy. There is no ulceration. Now, this is what start systemic HRT, and okay, so D is being the given answer. Are we going to start the systemic HRT? No, I don't think so. Vaginal epithelium is thin, dry, and friable. I think this D option which people are answering are for the previous question. Yes, Dr. Sushmita today is going to be the champion. Every question answered first. So start vaginal estrogen and refit in 6 to 8 weeks. Thin vagina, atrophic vagina, we don't need HRT. Oral HRT, we need only the local HRT, that is the vaginal HRT. So start vaginal estrogen and refit in 6 to 8 weeks. That is the correct answer. Very, very good. 61-year-old woman is fitted with the ring pessary in clinic. She is comfortable and the pessary sits behind the pubic arch. A finger passes around it and it is not expelled when she stands and strain. Which single step must be completed before she leaves the clinic? So, yes, that's, I think, the B option. Yes. B option, yes, Dr. Sushmita. Oh, okay, we have two Dr. Sushmita. Okay, so Dr. Sushmita Thuma, that is the B option. Confirm that she is able to void. That is very, very important. So we have to see that the patient voids. That is most important. Yes, here it's important to take the names here because some students have done it wrong. So I should take the names of the correct ones. Yes. So Dr. Divya, Dr. Barzam, and Dr. Yamini, Dr. Vijulakshmi, Dr. Srinivasan, Geeta. So you all have done it right. So basically, they are asking what to do prior to patient leaves the clinic. So this is one of those. 66-year-old woman has had ring and gel horn pessaries expelled. A cube pessary is fitted successfully and she is being taught to manage it herself at home. Now what? Which piece of advice is most important? Okay, so yes, now it is the B option. Yes, remove the pessary every night because this is the cube. So we have to remove the pessary every night. So yes, Dr. Chani, Dr. Salma, many of you have answered night. Correct. So remove the pessary every night. See, first option they have given you pull gently on the string, which is totally wrong. Wrong. Cube 6 concave sides exert suction on the vaginal walls, and this is what keeps it in, and it is what causes pressure necrosis, ulceration, and erosion. Okay, now this is about your, I think, the for the part three structure discussion. 64-year-old woman, para 3, is referred by her GP with a 12-month history of vaginal bulge and difficulty emptying her bowels. She had a vaginal hysterectomy 8 years ago. She is sexually active with her partner and works full time and is reluctant to consider surgery. Describe the assessment you would undertake in a clinic before offering her a vaginal pessary. So, what are the assessment points and what are the factors that predict an unsuccessful pessary fitting? She asks whether the pessary will work as well as an operation. What will you tell her? Outline the follow up you would arrange and what would you do to each visit. So, I think I'll give you the answers. So, what is the assessment? First thing is history. Take the history, do the bulge and the pressure symptoms, urinary voiding, urgency, and incontinence, bowel evacuation and splinting, sexual function. So basically, we have to ask about the urinary symptoms, bowel symptoms, and the sexual health. Ask whether she can attend regular follow up. So always remember these 4 points for the assessment are important. For assessment in examination, do not forget to add the chaperone. Inspect the general genitalia. Assess at maximal valsalva. Isolate each wall from the same speculum or a single finger. Bimanual examination to exclude a pelvic mass. Stage with POPQ, recording TVL and the genital hiatus. Then what are the predictors? So previous prolapse surgery, previous hysterectomy, short total vaginal length, wide genital hiatus, posterior compartment involvement, and the woman already has two of them. This woman had previous hysterectomy and the posterior compartment system terms, so she has high chance of failure. Now, pessary or surgery, 90% get better and 60% continue. So, we can offer her pessary plus PFMT that can actually go it better. So, pessary is reversible, avoid surgical rate, but it commits her to ongoing follow up. So, we can always counsel the patient regarding the two. If I talk about the follow up review at 4 to 6 weeks after fitting, this may be by telephone, in person, 6 months, extending to 18 months if she manages successfully. Each visit, check her comfort, fit, whether it feels mobile, and symptom control. Remove the pessary, inspect the vulva, vagina, and the cervix with the speculum for the erosion, ulceration, or any suspicious lesion, and insert it back. Silicone, same pessary may be inserted back, but for the PVC, you need to change at every time, and if it is cracked, split, or offensive, then we need to change. Ensure adequate vaginal estrogen and reevaluate at every contact whether a pessary remains appropriate. So these are the points and these are the references used, and the basic reference is the TOG article which I have included. And thank you so much for your patient listening. I hope you all enjoyed the session. Your feedbacks are welcome. Thank you for being with me today, and do subscribe to our channel if you have not done this, because we keep on conducting the YouTube live sessions mostly weekly. And comment with your answers below any specific talk which you find difficult or any guideline which you would like to learn like this. You are welcome. Else, in our course, we give bite-sized videos like 10, 12 minutes, 15 minutes video, which help you understand the concept so easily. You are welcome. And you can reach out to us at this WhatsApp and the MRCOG Okay, I hope you all enjoyed. Your feedbacks are welcome. Thank you. Thank you, Dr. Srinivasan Geeta, Dr. Sushmita Thoma. Thank you, ma'am. Well explained. Thank you. Thank you, Dr. Barza. Yeah, thank you everyone for joining. It's good to know you all enjoyed. And if you have any more questions, you can leave it here. I'll be happy to answer those. Dr. Veena Vangani, thank you. Thank you. Thank you so much. Thank you. If you still have any questions, you can leave them in the chat box. I'm here to answer. Dr. Salma, thank you. Thank you. Thank you for joining. Thank you. Yes. Anything else? Any questions? Okay. So I hope you all enjoyed. You can leave your feedbacks as well here. And yes, okay, bye bye. Take care. I'll see you again in the next live session. And we'll very soon have another one. But I would love to hear from you all what topics, what pointers you are looking at. Okay, bye bye. Have a nice evening ahead. See you all sometimes later. Bye bye. Maybe next week. Keep tuned, stay tuned to our channel, MRCOG Courses by Bhawna Khera, and we'll meet soon. Yeah, thank you, Dr. Shanazmi and Dr. Muthuselvi, Dr. Swati. Yes. Thank you, ma'am, for making one more topic easy. Yes, that's it. Okay, bye bye. Take care.